welcome along. This is the last part of a series that we've been looking at the National Autism Strategy. Just to go through the few housekeeping bits first, just to let you know that this session is recorded and it will be uploaded to our website once it's had a little bit of slight editing just to make it a bit tidier. And Annette will send you out an email to let you know when it's ready to be able to view. So anything that's on here will be shared afterwards. As we go through today, because there's so many people on the webinar, there won't be time for people to come on verbally and ask chat, so please do put your questions into the chat feature and we will go through them after each speaker for the time allows afterwards. Any we don't get to, we can forward on. So we will do our best to answer as many as possible, but hoping that you are going to find today really interesting. So as I said, today is the last in this current series. And so this is the agenda for today. So we are welcoming Mary Doherty to talk to us about some research that they've just been involved with, which will give a good background to looking at some of the problems around health inequalities and talking about the triple empathy problem. And then we've got Michelle Millard from BLMK talking about the new Learning Disability and Autism strategy that has just been published, and hopefully that will be of interest to you. And then we are going on to look at some of the experiences that some autistic adults that we talk to have experienced while accessing healthcare services. So we've got a few videos that we're going to be sharing with you. So we are going to just look at what the National Autism Strategy says. So these are a couple of the bits that are in there. Please do go and look at the website if you have not looked at the strategy before now, to find out what you should be doing. This current one is in place for another couple of years yet, so please do take a look. So one of the things is looking at improving health and care professionals' understanding of autism. And so obviously the Oliver McGowan mandatory training is now just starting to get rolled out. And this is in relation to this, where we're looking at improving health and care staff's understanding of autism. In the original strategy, it was all about autism awareness. Now it is very much about understanding, which is very, very different. And that understanding is crucial to make sure that progress is made in reducing health inequalities. And we've been doing a lot of work recently talking to autistic individuals, and some of the reasons that people aren't coming forward for appointments, some of the experiences that they've had, is usually not down to money being spent, but usually down to people's attitudes to them and their understanding of the differences an autistic person has in processing information, and keeping up with what somebody is saying and how they can communicate back to you things about feelings and emotions and everything, which is different to somebody who's neurotypical. And then the other bit is like developing the better understanding and looking at the causes of gaps in life expectancy and improving health outcomes. So out of that, we've got LEADER, which is learning from lives and deaths, which does now include autistic people. So I just want to share this with you as we start. So within BLMK, somebody's been gathering together a lot of data, and I'm just assuming if it's in BLMK, then it could be wider spread. But this is looking at autism diagnoses, and if you can see from 2010, that steep slope that is going up to current day. And this is across all ages. And when this data was broken down, there are an awful lot of people here that are in children's services where they've been diagnosed. But as we all know, it's a lifelong condition. And so all those children are going to be coming through to adult services. So the rate of people is coming up quite sharply, which is quite scary. But for us, it's showing that the prevalence rate that has been around is proving to be there. It's just getting all those diagnoses through, and obviously there's a big waiting list for children and adults, which we do hope at some point that waiting list will come down. And then some of the data, and this is taken from the BLMK, which is, Bedford Clinton and Milton Keynes Learning Disabilities and Autism Strategy, which Michelle is going to be talking about. But this just sort of underpins where some of it, to show that there are barriers because there are less people going forward for some of these cancer screenings. So that is just some of the underpinning of some of the work that we've been doing. And we're now going to go over to Mary. So I'm going to stop sharing my screen. So as you can see on the screen here that Mary is autistic herself. She's a consultant anaesthetist and one of the founders of Autistic Doctors International, and they've been doing some great research. So over to you, Mary.
Great, thanks, Heather. Excuse me, can I clarify, have my slides popped up?
I can see them.
You can see the slides. Okay, super. Let me just start this. All right, cool. Thanks so much for the invitation. Delighted to come along and talk a little bit about the work, some of the work that we've been doing. Mostly around autistic people in healthcare, the barriers that we experience, and the adverse outcomes. And what we've managed to do with our research is link the barriers to adverse outcomes and then develop a framework which offers a potential solution for meeting the needs of autistic people in healthcare. And just to give you, oops-a-daisies, what have I done? Where's my cursor gone? I wanted to first of all show you. Oh, sorry, I'm struggling a little with my slides, which I'm not used to. Anyway, hopefully you should be able to see the Autistic Doctors International website slide with the leadership team. Is that what's coming up for you? If somebody could just let me know that that is working.
Yeah, all working, Mary.
Perfect. Okay, super. Thank you. Sorry, I was doing some other work and I have changed around my screen, so I'm not quite used to this. And again, being autistic, I'm completely thrown by my screen looking different to what I was expecting. So if you can just bear with me for a moment while I recalibrate that and just regulate. Okay, so yeah, so the work that we've done in terms of research comes from Autistic Doctors International. And that is a group of autistic people, all medical doctors, who have come together for peer support and advocacy, but also research, education and training. And we started 2019 with 7 members, and we're now up at over 900 doctors who identify as autistic worldwide. That's our leadership team there. And the interesting thing you might notice is that many of our members in the leadership team, senior doctors, just cannot be openly autistic, and that's why they're shown there as silhouettes. The other thing that you'll see is our website, and the QR codes will take you there. And the second QR code is to our link tree, which is where we have all of our research listed. So just to move on to the research that we've been doing, 2 main papers really, and you know, we could talk for a long time about either of them, so I'm just going to give you a short overview. The first paper we published in, it's the bottom one on the screen, we published in the BMJ Open last year, and it's Barriers to Healthcare and Self-Reported Adverse Outcomes for Autistic Adults. And this was a study that was undertaken, it was a large multi-part study which was undertaken really to look at the barriers to healthcare and also then the self-reported adverse outcomes. And what we found was that the key findings really, you know, so much of it was to do with communication and access to healthcare and difficulty making appointments. So almost 4 in 5 autistic respondents avoid using the phone in general. We know that generally as autistic people, we tend to avoid it. But it was the most common barrier to healthcare access. Then over half avoided or delayed a needed GP visit. So the question that we asked was, about accessing a GP when you need to. So not in general, but when you have symptoms, when you have a need to access a GP. And over half avoided or delayed that visit because they didn't feel understood. So other challenges included sensory difficulties in waiting rooms, executive functioning or planning difficulties, concerns around disclosure of diagnosis as well. And in particular, communication difficulties were reported with both doctors and receptionists. And the thing was, difficulties with both doctors and receptionists in terms of communication, these were associated with all of the adverse outcomes. In terms of communication, we found that, most people reported that anxiety makes it harder to communicate. 2/3 described difficulty prioritizing when describing medical symptoms, and that sort of need to give the whole story and not leave anything out. That's quite familiar to a lot of us as autistic people. But this can create barriers in healthcare consultations. Over half reported needing extra time to process what was being said, difficulty describing pain, symptoms accurately. Over half found verbal communication difficult, with emotions being expressed differently, such as appearing angry, when afraid or in pain. And really important then as well to recognize that sensory issues make it harder to communicate. And all of these issues, they just resonate so deeply with me, but the adverse consequences were really stark. So we found that over 2/3 reported untreated mental health and physical health conditions due to access barriers. This led to late presentations, and 1/3 of the respondents experienced potentially serious or life-threatening conditions which had remained untreated, which is really, really important to recognize. The consequences that we found included, as I said, untreated mental and physical health conditions, late presentations, emergency admissions, and then more extensive treatment or surgery being required. Interestingly, we found no difference between self-identified or formally diagnosed autistic people in terms of difficulty accessing a GP, in terms of the barriers experienced, or in terms of the adverse consequences that they reported. So then going back to this slide, this was the slide, the paper on the top of the slide is the paper that we've recently published in the journal Autism. And this is the qualitative part of the project. So that's the human stories behind the statistics that we reported in the previous study. We had a lot of free text to analyze. There was a lot of stories that our participants told us. And the thing was that as doctors analyzing this data and just recognizing how medically serious so many of the consequences that people were describing actually were, that's where the idea of the triple empathy problem came from. And it's that sense of, we're all familiar with the double empathy problem. So that bi-directional mutual misunderstanding that happens between autistic and non-autistic people. The same sort of phenomenon happens with doctors and patients, with any profession really, teachers and parents, teachers and pupils. You see it in the justice system between professionals in the justice system and people accessing the justice system. So anywhere really where there's a professional and layperson interacting, the same type of phenomenon happens. But when this happens in healthcare for autistic people, it's a double disadvantage. It's a cumulative barrier to accessing communication. And we found this when even autistic respondents who identified themselves as healthcare professionals, they were experiencing the same sort of barriers accessing healthcare. And we shouldn't really, you might think we know the system, we should be able to access healthcare, but no, as autistic people, we have the same sort of barriers. And that sort of, that it almost took on a three-dimensional sort of sense in terms of the way those barriers were interacting, and that's what we have called the triple empathy problem, building on Damien Milton's concept of the double empathy problem. And that insider perspective allowed us to look at the way that the barriers, the access to healthcare barriers interact and link together to lead to potentially adverse outcomes. So we looked at, how early barriers such as difficulty accessing the surgery, needing to get to appointments, communication differences, how that all led to that communication mismatch, and difficulties in the interaction between patients and healthcare providers, and how that negatively impacted the doctor-patient relationship, how that could potentially lead to diagnostic overshadowing, or everything being put down to an autism diagnosis, for example. Oops, sorry about that. And then the sense of, people trying and just not being able to access healthcare, and leading to the sense of learned helplessness, fearing repercussions, people not wanting to disclose a diagnosis, for example, and then how that can lead to healthcare avoidance, and then lead on to potentially serious consequences. So in practice, that translates, for example, as somebody not accessing healthcare screening, not accessing healthcare with early, potentially treatable cancers, for example, but turning up much later with potentially malignant, potentially metastasized malignancy, which is, obviously, not what we want. We want autistic people to be able to access the healthcare services that are available. To address these issues, what we did was we developed a framework, which we've termed the Autistic Space Framework. It's a novel framework for meeting the needs of autistic patients in healthcare settings. And this is open access. All 3 papers are open access, and the QR codes will take you there. And this framework was developed from a concept that's very dear to autistic people, that of autistic space. And that's really where it's places and events where autistic needs are prioritized, where autistic people set the agenda, and where things are very different, really, to a sort of the more usual non-autistic space. But we've used that concept as an acronym for what we believe to be the core needs of any autistic person in any setting. And SPACE, it stands for sensory needs, predictability, acceptance, communication, and empathy. And that rests on a foundation of 3 other domains where the principles apply, and that's physical space, processing space, and emotional space. And we published this paper in the British Journal of Hospital Medicine earlier this year. It's been incredibly well received. It seems to meet that gap in terms of healthcare provider knowledge. Because for so many people, autism is very nebulous. It's very difficult, particularly because of the heterogeneity among autistic people, to figure out what it is that we all share, for example, and what it is that we all need. And this is just a nice, memorable framework where people can just make simple changes that can make an enormous difference for autistic people in healthcare. And while I wish we had time to go through it in more detail, I'm more than happy to take a few questions if we have time, or indeed to be contacted about this. What I would love to see is this on posters, on flyers, in the walls, on the walls of all sorts of healthcare settings, and for people to just use this as a way to improve access to healthcare for autistic people. So I shall leave it at that for now.
Thank you, Mary. That's really interesting. I'm just looking through, there's a couple of questions have come up. And one person asked, you said at the beginning that I think it was 3 of your colleagues cannot be seen as openly autistic. So they're asking why. I don't know if you're able to answer that.
Yeah. Basically because they would put their careers at risk. There's 2 strands to the work that we do, and one is healthcare for autistic people, but the other is the needs of autistic doctors and autistic medical students. And there is a very pervasive sense in healthcare that, well, autistic people can't be doctors. We shouldn't be doctors. There is, unfortunately, the prejudice is really strong. And we in ADI, we have had experiences where we've had members who've been released from medical training, like literally, ejected from their training programs, because they've disclosed a diagnosis of autism. We've had medical students who've been removed from their courses, who've been put through additional fitness to practice inquiries, additional assessments, additional exams, really prejudicial, really discriminatory. And it is a privilege for me and other colleagues to be able to be openly autistic. But for some, it's just simply not safe. It is absolutely discriminatory and against the Equality Act and illegal. I completely agree. Now, what we have done, there's actually another paper. If you look on our link tree, there's a paper about supporting autistic doctors in primary care and general practice. And we relate a case of one of our members who was ejected from training, but we did help her. We did support her to challenge that decision, and she was reinstated and got an apology, which was really helpful to see. But for some, it's just simply not safe. The other thing is people question our competence, people, particularly for our psychiatrists, because that's one of our biggest groups, but they're the least likely to disclose, because the sense is, well, if you're autistic, you don't have empathy. Now, we know that's nonsense, but that is really pervasive. That view is really pervasive. And it's like, well, how could you be a psychiatrist if you've got no empathy? It's total nonsense, but we are really trying hard to battle against that and to raise awareness.
Thank you. You mentioned earlier about the double empathy problem. I'm thinking there'll be some people who might not have read Damien's article. Do you know where that can be found? I don't know if people just Google Damien Milton and read it.
Yeah. There's a lovely explanation on the National Autism Society website, I think, about the double empathy problem. And it's just that idea that autistic people, because when autistic people and non-autistic people have challenges communicating with each other, the traditional view is that, the autistic people have communication deficits. Absolutely not the case. We just communicate differently. And there's research by Catherine Crompton, which is super, which shows that autistic people communicate amongst ourselves just as effectively as non-autistic people do. And that double empathy is about understanding that, we have a different perspective and a different way of communicating. And neither is, defective, really. So it's just important to understand that we have different perspectives and different ways of communicating.
I personally had an interesting insight. We were having a meeting with some autistic ladies locally to where we live, and I am married to somebody who is self-identified as being autistic. And there was an autistic lady there, and she was talking about her neurotypical husband. We both had the same what are the words? Frustrations, but from the completely different sides of looking at things. And that was really interesting to me, that what she was saying was resonating with me quite well. But we were coming from different sides of the window, that pane of glass that used to get mentioned a lot. So just two more things have come up. Working with autistic colleagues really enhances our service, definitely. And I think for those of us who, work a lot around autism, there's a lot of professionalisms that you would much prefer an autistic person to be doing that work, because you would know that it was going to get done a lot better.
Yeah. Absolutely, yeah. And the other thing that really matters is the sensory environment, particularly because we will see the sensory environment very differently to how non-autistic professionals will. So you might have an autistic person in a particular service really distressed about some aspect of the sensory environment that you're just not going to notice if you're not autistic, whereas we will see that as autistic people.
Yeah. Oh, well, thank you so much for giving your time today for us. And it's been really insightful. So I'm hoping people are able to download your poster for the space and share that with colleagues, because it's really great work. So thank you very much. So we're now going to just pass over to Michelle, who is Commissioner within Bedford, Luton and Milton Keynes Integrated Care Board. So again, I will stop sharing my screen so that Michelle can share hers. So over to you, Michelle.
So as Heather said, I'm Michelle Millard. I'm the Learning Disabilities and Autism Commissioner at Bedfordshire, Luton and Milton Keynes Integrated Care Board, BLMK, ICB for short. I work with the Senior Commissioner, Casey Conroy, who unfortunately couldn't be here today, and we sit within the wider mental health, learning disabilities and autism complex care team within the ICB. So why did we do a learning disabilities and autism strategy? Well, it was always our intention to have one, particularly looking at the health inequalities agenda, and Mary's presentation before just, you know, reinforced so much of what you're going to be hearing throughout this presentation as well. The main issues always come up about diagnostic overshadowing, the person not being spoken to directly, etc., etc. But more about that later. When the national strategy was published, you know, we wanted to wait until that kind of was out there before we kind of did our own thing, so that we could also mirror that within our work. We have good quality local data, including annual leader reports, as well as information from colleagues and partners. So we decided within the ICB to use a quality improvement framework as a basis for doing our strategy, and there are many reasons for this. And the work commenced at the beginning of this year, so in January, within the governance structure of our learning disabilities and autism, reducing learning disabilities and autism health inequalities steering group, a bit of a mouthful, that one, in conjunction with wider healthcare and social care colleagues. Looking at the data we had, we developed an outline plan for producing the strategy. The QI approach involves people with lived experience right from the beginning to make sure that the strategy represents what they wanted and not what we thought, although obviously we do have some data, but we didn't want to just use data exclusively. The QI approach is also a very structured one and is proven to support measurable improvements. So the first QI step was to discuss within our steering group which areas of our population face the greatest health inequalities and who would benefit most from targeted interventions. So from this slide, you could see some of those things. We identified people whose first language isn't English, LGBTQT plus community, young people transitioning to adult services, ethnic minority groups, forensic or the criminal justice population, people requiring weight management, and people with comorbidities, particularly mental health illness and or complex behaviours. And again, you can see here there's a statistic that males with a learning disability are less likely to have an annual health check than females. So that is also in the forefront of our minds, although again, not here, but we do know that females mask more. So, you know, there's a reason to focus equally across all genders. So we identified various needs here from the data. Again, I won't go into it in too much detail, but, you know, increasing numbers of people on the learning disability register, people with a learning disability with comorbidities, for instance, obesity, depression, asthma. People with a learning disability are 24% less likely to receive bowel cancer screening, and Heather shared some of these statistics right at the start of today's session. People with unknown ethnicity, etc., are less likely to be checked than others within the population as well. So again, we just wanted to work closely with the population to see what they had to say. And we commenced an an extensive engagement session drive across the BLMK region. That was also part of, well, in addition to actually what's already been done and continuing to be done through the Denny review that the ICB is conducting. People told us about various issues, which we then later themed. So the first was difficulties with GPs. Again, Mary mentioned this about, what was that statistic? 60% of people with autism really rather not use the phone and will not use the phone to make an appointment, etc. 55%, Mary said, didn't feel understood when they go to an appointment, and therefore less likely to present for checks that can actually help them in the future. Another thing that people said was about going to the dentist. We had people saying, they hadn't been to the dentist in many years. Interestingly, though, I have to say the majority of people did say they had a really good experience with their dentist, which was the reverse for GPs. Most people said they had difficulties in some way or form accessing primary care services, whereas most people, we were really pleased to hear, had a good dental service who they found was responsive, etc. But you can see, due to one negative experience, someone hadn't been for, over 15 years to the dentist. And we know that dental issues are linked to healthcare issues and life expectancy and mortality. So that's quite a serious thing indeed. Broken trust. This lack of trust came up quite a lot. Again, Mary alluded to this. And that makes people not want to access healthcare. They see letters, they just bin them, we were told. And obviously that's not what we want to hear. We want to be reaching people and having people feel comfortable to approach their doctors, their dentists, their community health professionals across both health and social care. And here it says autistic people were over 7 times more likely to report that their senses frequently overwhelm them, so they have trouble focusing on conversations with healthcare professionals. And yeah, it's certainly an issue. The next one is fear of the unknown. People don't attend for appointments because they have no idea how long it's going to take, what it's actually about, what's going to be involved, what type of equipment's going to be used, where is the appointment going to be located, how easy or not is it for them to get there, are reasonable adjustments going to be made, for instance, longer appointments, or even from the outset, not knowing what it's about. I met with a group of people yesterday in Bedford, and one person was telling us of a really good experience, which I was really, happy to hear about, where she had to go for a bit of an invasive investigation, and she didn't understand. And she was able to make a separate appointment with that consultant who went through everything with her. And because that was done, and because everything was explained, because, the patient was adamant that they didn't need that intervention, and went in with that premise. And then the doctor said, well, actually, we think you do because, and it was explained, we found this is why it's important to do so. And because that consultant took the time to have that interim appointment with this patient, the patient was very happy to then sign up for, if you like, to have the procedure. The consultant said, if I put you on my list, will you come? And you said, yes, because I trust you. So that links back to the previous one as well. But addressing the fear of the unknown is so important. We can't assume that just because it says this is what you need, that people understand, because we don't. Even neurotypical people don't, but it's really more important for people with learning disabilities and autism that we acknowledge this and make sure we address this. They also told us about what it means to them to be healthy. And, you know, these personal stories, so important, not only to listen to people themselves, but these later on helped us to develop a more targeted and appropriate action plan to address some of these issues. We heard lots of patient stories. This one's about Zoe, who's a wheelchair user. And again, it's that diagnostic overshadowing. It's not recognizing her as a patient. It's speaking to her carer instead of to her directly. It's assuming that she's deaf, she's dumb, and she can't advocate for herself, none of which is true. You know, shouting, it was horrific. Luckily, Zoe has a fantastic sense of humor. And, you know, she won't stand for it, which is great. But many people feel, you know, undermined. There's a bit of kind of white coat syndrome, and, you know, where they don't feel able to speak up for whatever reason. And we need to be aware of this, and we need to educate our colleagues across health and social care about this. Pauline's story relates to medication difficulties, differences in size and shape and colour, and when medications are stopped and she's not advised, or things have changed, or it's out of stock and she turns up and it's not available. And these are things that within healthcare and pharma we need to be aware of, and how that impacts someone with autism, someone, an autistic person, or someone who has a learning disability, and bear that in mind, because that can then have a knock-on effect for them accessing their healthcare, even turning up to receive medications in future. And these are the key takeaways we got from what people were actually telling us. That just summarizes what we saw earlier. So the next step was to go back to the steering group with all the information we had, and really consider who else should be involved in this work. And we then decided that we would involve our voluntary community and social enterprise colleagues. So we held a separate session, which was the only one that wasn't face-to-face, for loads of different people to actually see what we developed so far and give us some additional ideas and input into this really important work. And this here is just a summary of the individual sessions we did in Milton Keynes, across Bedford Borough and Central Bedfordshire, in Luton, and that session I was saying that was virtual for our VCSE colleagues. Obviously, we also engaged across the ICB with the various professionals and wider, so involving colleagues at East London Foundation Trust, ELFT, CNWL, our local authority partners, etc. We were actually very keen to make sure that interdependencies were acknowledged, because it's not a standalone one. So I mentioned right at the beginning, we waited until the national strategy was published to make sure our local one was aligned, but also we wanted to make sure it links in with all other local and national priorities, which are listed here. We heard lots of powerful I statements earlier, and we were keen to use some of them, one in particular: if I feel healthy, I feel positive, I feel happy, to develop our kind of, lost my thinking there, our key theme and purpose for doing this strategy, which is listed here. And I've got something on the right side of my screen. Sorry, I've just got one screen today. So I'll let colleagues read it, and the slides will be circulated. So from everything people told us, we summarised that into 5 key themed areas. Again, using some I statements. Our aim of this, which is we will work in partnership to reduce inequalities for people with learning disabilities and autistic people by listening to people and increasing awareness of their needs. Our overall aim is to improve access, improve well-being outcomes, and reduce premature deaths, again linked into the LEADER work that I mentioned earlier. And some of those I statements about primary care, dentistry, cancer screening, mental and physical health, and previous poor experiences which influence ongoing attitudes and access to health and social care are listed against these themed areas. And again, keeping those themes, we've kind of added some of the areas of work, the existing and future work streams planned to address those. Step 5 of the QI plan is about measuring improvement and what we're going to be doing in the future. So tell us whether the aim is achieved, how are we going to influence this, and what happens going forward. So before I look at stop sharing, etc., my colleague Casey Conroy has developed a very comprehensive implementation and delivery plan, which is the follow-on from this actual strategy. So that has been ratified through the steering group I mentioned, and also by the ICB's board. The strategy will be available on our website, the ICB's website, and in future that link will be circulated with colleagues, etc. My colleague Simone Mingay from ELFT has kindly done an easy read version of the strategy as well. So that's going to be available too. And we have not just stopped there, because both the strategy and the implementation and delivery plan are 3-year plans. And the reason behind that is it's an ongoing process. So we decided right at the beginning, also partly to address that broken trust aspect, because what we're hearing is, you know, people have been approached previously. Yes, tell us what you think. And then they're like, we never know what's happened to that. Were we taken seriously? What's actually been done? So we undertook right at the beginning that we wouldn't do that. We would absolutely go back to all the various groups we engaged with to let them know what the outcome was. Firstly, i.e., here's the strategy, and show them where what they told us has been incorporated and used. And secondly, to have an opportunity to look at the implementation and delivery plan, tell us if anything's missing, add to it, again, input, so an ongoing dialogue. So we have started going back to these groups. So Casey and I went to a group in Milton Keynes last month. Yesterday, as I mentioned, I met with a group in Bedfordshire, and next month in December, we're meeting with a group in Luton, and we're going to be connecting with our voluntary and social enterprise communities as well. Yes, I think I'll stop there because I've waffled on for quite a while. and I will stop sharing.
Thanks, Michelle. Somebody's put in the chat here that their local community dentist, who supports many individuals with LD and autism, will now only take referrals from another dentist. But when most of the individuals don't have dentists, that obviously doesn't work, and so there's another barrier. And it is looking at all those procedures, isn't it, to see what is broken and what can be
Absolutely,
changed.
and that's why, you know, thank you to Heather and the team for inviting me to kind of highlight this here today, because every time we talk to people, we get other ideas and we become aware of other areas that we really do need to address. So that is something that I can discuss with our health facilitation colleagues across BLMK and have a discussion. So there we have a learning disabilities annual health check steering group, and of course people with autistic people are also included in the leader reviews now. So we're keen for them to also have annual health checks. And as part of that steering group, we have a task and finish group that discusses key areas like this, and we bring all heads together to see how we can actually address that. So thank you very much, Tricia, for bringing that to our attention. Yeah, that's something I'll take back.
Thank you. And Fiona, I've just done a quick click on the link that you sent through, so I haven't got time to look at it, but it's a report taken by GP Services. I will be interested in reading that through because some work that we've been doing locally, and it was same sort of information that Mary was sharing in hers about trying to get through to a GP, the telephone calls and waiting on the phone, not knowing when someone was going to answer. Or people would say, right, the doctor will ring you back this morning, and the phone call comes later on in the day. The trust is broken, and so people are just not going forward for it. There was one lady who said to us, she didn't think things were right within her, and she thought it might be urgent, but not really important. And so she tried for ages to get through to see a GP, and it did turn out that she had cancer, and it was the start of cancer that she was feeling, and then got told off for not saying it was an emergency when she rang the doctors, and she was saying, I didn't know it was an emergency. How was I supposed to know it was an emergency? I just wasn't feeling right. So it's all that information, and if that barrier is at that first door through, the first hurdle, then that's the one that needs to be dealt with, so that everything else then might fall into place afterwards.
Yeah, and you know, that's something you know, we've been hearing consistently for some time now. So it's great. You know, Heather, you mentioned earlier the Oliver McGowan training has started to be rolled out, and I certainly received my link last week or the week before for the training, which I've completed, and that was 2 lots of online ones, and the kind of face-to-face training will follow, I believe, in the new year. But you know, within Bedfordshire, Luton and Milton Keynes, you know, we've taken this feedback that we've been hearing and about the requirement to train and raise awareness of autistic people and their needs. And, you know, we've commissioned Autism Bedfordshire and we've worked with other organisations as well to do such training for GPs, the forensic teams, police, and also, you know, social prescribers. So yeah, that's kind of, you know, we listen to all feedback, and we're just trying to address that as we go along. Like I say, the implementation and delivery plan is the 3-year one. So, you know, obviously we can't do everything in year 1. So some work is in train to be completed by the end of March, or might actually go over. But other things we're just kind of plotting in to make sure that it's a continuing journey. And again, part of which, like I mentioned earlier, is by having such discussions like we are now amongst the professionals, but also going back to people with lived experience to see what they have to say, and picking up any new experiences, good or bad, that they might have, because good practice is equally important to hear, so that we could replicate that and say, we need this is what we need to be aspiring for, this is what good looks like, and this is actually where we need to raise the bar somewhat.
Yeah, definitely. So I think for people who live in different areas across the east of England, if you're thinking that this sort of strategy is something you should be looking at and need some advice, I'm sure I'm just going to drop Michelle right in it. That she'll be happy to take an email from you. So just get in touch with us, and then we will pass it over to Michelle. So that would be on the Annette sent an email out for you to come on today, so just replying to that email address. But thanks, Michelle, and thank you for stepping in for Casey, and let you get on with your day. So thank you very, very much.
Thank you.
Right, I'm just going to share my screen again now, and making sure that I've got sound on, because I will now be showing some videos. So I'm now going to start introducing some of our voice group members. So we do some work meeting up with autistic adults, some who are carers, some who aren't, and listening to their experiences. For every autistic person, how they communicate with us is different. And so we have some people who are very happy to come along to a filming session and be on camera. We have some who are happy to come along and maybe not be on camera, some who come along to help us, and they want to get the message out to professionals. They want professionals to change what they're doing. So they will put themselves out, they'll come along, but actually not be that happy at being there. And then others who will join us remotely, that we will do online calls with, and some who will email us some of their information through. So what you're going to see now is a mixture, basically, of all that. And this, in a way, is just giving you a chance of like how some reasonable adjustments are put into place, because we do things in different ways for the people, how they want to communicate it back to us. So we're going to start off looking at appointments. So we asked people what issues or experiences that they'd had that prevent them from attending appointments. Then we always ask, what could be done differently. So for one person who did not feel she could attend a filming session, the reason that her adult son will not attend any healthcare is mainly due to trauma caused by appointments he had as a child. There were no adjustments made then, and he was forced to undergo treatment without any understanding of what was going to happen. And as a result of that, he does not feel safe or trust health professionals. I'm just realising that this word trust is coming up quite a lot today. So, from a very young age, he is already being put off going to get any help. And now we're just going to play this video, and you will hear from people by voice.
I would say getting the appointment is quite hard, so sort of ringing up. And I have to get my partner to ring up, and then he has to explain on the phone that he's my carer. And then it's sort of getting the appointment, and then I find, so that's like the first barrier is sort of getting the appointment, and then getting the appointment time that is best suited, so not in the busiest time. And I find that sort of one of the barriers, and sort of trying to avoid getting a telephone appointment, because at the moment it's very much we can get a doctor to call you today, when actually I find it hard to talk on the phone. So it's trying to avoid the fact that actually we would prefer to see a doctor face to face, but of course then that delays the appointment, because of course they say, well, can you ring back the following day at 8 o'clock in the morning? So it's sort of like you're on this delayed sort of thing. So even before you get through the door, there's sort of like delayed sort of thing.
Yeah, it's really hard because to get appointments, the only way you can get an appointment at a lot of GPs now, including mine, is to call them up. And I find that very difficult. I don't like calling people up because I get very anxious about it. And I've had quite a few bad experiences ringing my GP where the receptionist has answered and been quite rude, because when I get anxious, I tend to stutter a bit, or I don't always know what I'm saying. Like I've got the words in my head, but they won't come out in the right order. And then the receptionists in the past have got quite angry with me for that, and then that just makes me more anxious. I also don't like having to tell the receptionist what the problem is, because firstly, I think really that's something that should be between me and my GP or the nurse. And secondly, on several occasions when they've referred me through, they've sent me to a nurse, and the nurse has immediately said, "Oh, I'm not sure why they sent you to me. You should have seen a doctor." And yeah, so that's what stops me going to the GP, really.
For us personally, it was better in COVID because we had Zoom appointments, which was a lot easier for her because she didn't have to leave the house, especially when we were seeing the hematology or the diabetic dietitian. So to see the diabetic dietitian, they don't have one in the community, so we have to go to the hospital to see her. So again, that's very stressful. We did try the park and ride to our local hospital, but again, that was very stressful. The buses, noising, lots of crowding on the bus, so that didn't work. And often as well, if they're running behind, you then have to go out and put more money in for the parking meter, and you've gone for the results and they can't find the results, or they don't know what the results were. I think things like that, they could just tell you over the phone, rather than put my daughter through all the stress of taking her there for then go, "Oh yeah, the test results was normal." All they need to do is communicate more. I think if they just took the time, especially with the vulnerable adults, if they just took the time to maybe send them to ring them rather than sending everything through letter, because then you can have a two-way conversation and say, "Well, that time won't suit us," or "Can we come in early?" Like my daughter with her social anxiety disorder, being around crowds and lots of people was very distressing for her. So we would prefer like first thing or last thing rather in the middle of the day. So I think if it was just the receptionist, medical receptionist just rang and said, "Oh, hi, we've got this appointment. Is that time better for you? Or is there anything we can change so Harmony's more comfortable?" I think that would help.
I just like to say that, like, not autistic people are the same. And I think sometimes that sort of, people constantly think that, like, you may say one need is your need. And then they automatically think that the next autistic person who comes in, they have the same needs, so they may not ask, they just sort of make assumptions. And so if one person says they want to be in a quiet space, and they make the assumption that the next autistic person might want to be in a quiet space, but actually that autistic person might not want to be in a quiet space. So it's actually sort of asking that person what their needs are, and that rather than sort of just making the assumption.
So that was, sorry, just stopping this to move it on. And then we had from somebody else that they recently had an appointment letter which just gave the first name of the doctor and the appointment time. It didn't say whether the doctor was a psychiatrist or a psychologist. It did not say what the purpose of the appointment was for. When they rang the receptionist, they couldn't tell them straight away who the doctor was, and she was on the phone for 10 minutes and was getting very stressed. During that time, the receptionist listed all the diagnoses. I did not know why she did this, and I don't think it was at all appropriate for her to do so. The appointment was a review with a new psychiatrist. The last one was 6 months ago. I'm supposed to have them every 3 months, and this was also my fourth psychiatrist in 2 years. So, there's obviously not a lot of consistency of delivery there either. But that's one person's experience. And then this was a suggestion from It was the care of an autistic adult who thinks that she might be, the carer thinks she's probably autistic herself, that they've been trying for many years to get GPs and other healthcare professionals to consider opening up once a month to allow autistic children to visit the surgery or the dentist or the optician, etc., so they can meet the clinician without needing treatment. They can have the tools explained and understand the sort of things that may happen at these appointments, which will build trust and reduce fear. If clinicians did this, then I'm sure many autistic children would be able to access healthcare more easily. And this is something that we ask an awful lot of society to do. With theatres, that they will often let somebody go in the day before to have a look around. Lots of places will just let that familiarity visit happen first. And so when you think that something like a theatre is like a very pleasurable experience, for going to somewhere within healthcare, it's usually fraught with anxiety anyway, because of the reason that you're going. So to actually show what's behind those closed doors, so they know what to experience, then that can be really good. And we are in the process of doing some work with Michelle and the ICB at looking at some accessible videos to show some of the experiences, to take away that fear of the unknown, to know what to expect, to maybe do a tour of, say, like a breast screening unit to show what is within that big caravan that's parked in the car park, what is behind those closed doors, what is expected of an appointment once you get there. So then understanding the different needs, what do health professionals, do they understand the difference in needs? So these are experiences again.
I know it's a spectrum disorder. I know everyone under that umbrella is different. But I think having a little bit of knowledge, or even putting on her notes, whoever's referring her says, this is Harmony, these are her needs, this is what she can do, this is what she can't do. Some of the appointments will go all the way to the hospital and they want to examine her. She doesn't want to be examined because she doesn't like the touch. And then you feel like you've wasted their time, you've wasted your time, because they don't want to talk to you. They just want to have a quick look at whatever the situation is. And then it's like, oh, well, we can't do nothing to help you by. They could have said that on the phone. So, yeah, I think it's lack of knowledge. And I think they need to the doctors, when they're seeing you, they need to be a bit more aware of why they're seeing you and what your needs are.
I just like to say that, not autistic people are the same. And I think sometimes that sort of, people constantly think that, you may say one need is your need. And then they automatically think that the next autistic person who comes in, they have the same needs, so they may not ask, they just sort of make assumptions. And so if one person says they want to be in a quiet space, and they make the assumption that the next autistic person might want to be in a quiet space, but actually that autistic person might not want to be in a quiet space. So it's actually sort of asking that person what their needs are, and rather than sort of just making the assumption.
When you've got, as an adult, that's neurotypical, you can ring 111 and explain your needs, or if there was something wrong with you, or but when you've got an autistic daughter like I have, who's 21 and is non-verbal, she can't really tell me what's wrong. She can just say that she's in pain. But equally, 111 will say, oh, you need to go to A&E. But actually, it could be the pain where she is could be in a different area. It's not where she says it is. And going to a hospital is far too distressing for her. So to pop up to my local doctors, which is less than a mile away, would be a lot simple. I think with technology is going so far forward, when it comes to patient care and understanding of everyone's different conditions, I think we're so far behind. Like, autism isn't something new. It's been going around for years, and yet we still don't cater for people that are autistic. Just like we don't cater for people that are disabled. Hospitals are getting better now, but in terms of autism and needs, yeah, they need to come a long way. They need to improve the service, yeah.
So with the Hear Me team, we've been holding voice groups, and over the last, I think probably 6 months, we've been developing the self-advocacy booklet, and which started off as maybe like a health passport, which quite quickly changes, which is what usually happens when we're with voice groups, of where we go in with an idea and it very quickly gets changed to something that's an awful lot better. And what this self-advocacy booklet is it's got lots of pages in it, and it's people can add more pages to it, and they can download whichever pages they want for them to fill in for themselves. And it's showing some things around what are my sensory needs. You know, have I got a sensitivity around smell? What is that sensitivity? And where when they're feeling in a very sort of like calm place with themselves, and often filling in with somebody else with them, and being able to write down everything about themselves, about what the sensory needs are. What do I need to do if I need to ring somebody for an appointment? And that appointment could be with a health professional, it could be to get a plumber, it could be to get a job interview. What do I need to do beforehand? What do I need to ask them to do beforehand? And so that they're writing down as much information as they can, so that then when they are in a position where they need to do it and their anxiety is going up, they can self-refer back to this booklet and to see what they've already planned that they need to say. And it's also, we do hear from some autistic adults who are very eloquent. When they go into an appointment, their anxiety goes up through the roof, and their ability to speak disappears completely. So then if they have questions written down that they want to ask, they can just hand those questions over, and hopefully they will take an advocate with them, because if you're stressed, you don't usually take information in. But one of the questions in there would be, what do I need from the person I'm going to see? And it might be, I need them to follow up the appointment with what they've told me in an email, or written down somewhere, so that I can process that information afterwards when I'm not feeling anxious. And that is quite often the case, is that somebody goes into an appointment, they get told something, they come out and they haven't got a clue what's being said, because they've not been able to retain that information because their anxiety is too high. And for some of these things, it will help the general population as well. It's not just autistic people, because lots of people get very, very anxious. But anyway, that self-advocacy booklet is now up on the website. The group that have been creating this are very happy with this, and they're glad it's up there. So we're just hoping that it is of use to as many people as possible. And then just got the link in there for the National Reasonable Adjustment flag, that you can get more information on there. Tracy Brennan is on this call. She knows everything about it. If you want to get in touch with Tracy, she'll love me for that. But that is, there's a lot of stuff going on with that for it to be going live next year. And that is where all these reasonable adjustments should be recorded for the patient. Right, now communication aids. We've got a lady who is a really, really eloquent person, until she gets into a group of people, and then she finds it hard to talk at times. She will talk, but then she is increasing her own anxiety a lot by doing it. So she has this communication aid, and we asked her if she would show us what it was. So this is part of like reasonable adjustments of, if somebody has one of these and you think, but they're talking to me fine, it might be that their need for it is just not as visible to you as it is to them. So this is her explaining this communication aid with me asking her a couple of questions as it goes through. Please let me know if you can hear her. She isn't going to talk for the first bit, by the way.
Sorry.
But you know, you can go as soon as you.
Yeah, I know. It doesn't make, it's not logical sense. I volunteered, I said I will be here. You have not forced me to be here. I don't have to come, but as soon as I get out, and I'm just like, I want to go home.
Well, how about we give you 15 minutes and you can go?
Yeah.
Do that. And see.
Okay, well, I'll leave that because it just complicates everything. It just makes, and that's the problem I'm finding with it. It just makes life a lot more complicated. And I suppose that is part of why people don't use it, because it is changes things.
So can I ask you about that then? Do you have to, so if you were going to the doctors and you can write things down beforehand so that you know what to ask when you get there, and if when you get there, do you remember Owen said before that sometimes he just goes mute when it's anxiety?
That's right, yeah.
So if you were like that, could you hand that over to the doctor so the doctor could read it on there instead?
They can do, but you can talk at the same time. So I don't have to, I can use this as a replacement for my voice. So look.
So I can use this as a replacement for my voice. It just takes longer to do. Because you need to wait for me to type. It is a voice replacement tool.
And if you aren't good at typing, will it mispronounce the words?
So it does do auto word. Also, there is another version which uses pictures. That gives sentences. It is really good.
And it helps lessen your anxiety.
But it changes the dynamics of the conversation. I find talking very anxiety making.
So do you find that less stressful using that?
Yes.
So I know how eloquent you are and how passionate you are about talking about something. So because you have to slow down as well, does that take away some of your eloquency and some of your passion? And then make you more frustrated?
There is no feeling in this. So you do lose something of yourself. But I'm so exhausted when I get home. I cannot function. This helps to improve my ability to function.
Yeah. And actually looking at you, because you have to concentrate on that, you've calmed down. So I can see how it's helped in some ways.
I seem to have a big problem with verbal communication. It causes me massive anxiety issues.
Yeah. Yeah.
I don't fully understand.
No. And sometimes I doubt anybody can explain it to you either, can they?
No.
So she left just after we'd done that short piece. She'd helped us out on some filming about a month earlier, and she'd stayed too long. Some people can't be around other people for that long. And so she was with us for about 20 minutes. The time before, she'd stayed on for about twice that time, and it had taken her a week to recover. She stayed with us for 20 minutes on this session. And when I contacted her the next day, she said, although it had really taken it out of her, the next day she'd actually started to feel a bit better quite quickly. So it's just knowing the time that a person can be there. So if you are meeting with somebody and it needs to be a long process, you really do need to think about breaking that down into maybe one or more visits, so that the person isn't so anxious that they're actually then not able to give the information over that they need to, that they're going to give the correct information, that they might not be able to start answering the questions, or be receptive to whatever the treatment is that they're coming in for, but where you have to be a bit more flexible with that. So we're now, I just want to share this with you. This is something that we've been doing for a different project that we're doing, but we filmed this, and I think it's something that is really worth sharing with you today. I find it really distressing with what you're going to hear, but it is something that happened, and it is something that does need to be thought about when we're looking at inequalities, of what can happen with a person. And it's thanks to this lovely young lady for sharing this with us.
It's probably over 10 years ago now. I went for one, and that one was quite good because it was at a doctor's surgery that the nurse there was very patient with me and very calm. And she taught me through what was going to happen. She explained everything. She said it probably will hurt a bit, but I'm going to make sure I get like the smallest speculum for you. And if at any point you don't feel comfortable, let me know. So that one went fine. So, I was quite confident when I got called up for my second one, but this was at a different surgery many years later. And I turned up and I said to the lady, I'm going to need the smallest speculum you've got, because that's what they used last time. And she basically said, oh, don't be ridiculous. Like, you don't need the smallest one. I'll just get the regular small. I'll be fine. And I will mention this because it's quite important. I said to her, I'm a virgin, and that's why I can't deal with anything bigger. And she just laughed at me and goes, yeah, they all say that. And went and got the regular small, and got me in a very uncomfortable position on the bed and basically jammed it in, and I was screaming in pain. And she wouldn't stop, and I was actually shaking. And she actually caused quite serious damage because I was having a lot of bleeding after that. I wasn't well at all for about a week. And I've never been back since. It just frightened me so much. And the fact that she didn't listen.
So could somebody do something to encourage you to go back again?
I suppose if I could be assured that it would be more like the first time I went, because she was very calm with me, and she didn't force me to go through with it. She said, you can stop any time.
I get bugged about going for a cervical screening several times a year. I've actually explained to the doctors and the nurses why I'm not doing it is because I've been treated very badly in the past by a nurse. And there's never been any sort of, oh, don't worry, we'll help you through it. We'll make sure it doesn't happen again. It's just sort of more pressure, like, oh, you need to do it. And it's like, well, instead of pressurizing me, can you assure me that I'm not going to be treated that badly again?
So I have exactly the same experience. So they have to use the really small spectrum. For whatever reason, I cannot use anything bigger, and they can't, to make it without sounding crude, they can't get it in, basically. there's something, my body will not allow them to do that. And I've had to have quite a few smear tests over the years because I've had polyps, and then I've had this, a cyst, and every single time it's the same issue. So but they've had no choice. They've had to do that. I mean, I've been lucky. No one's actually forced anything inside me. But I haven't been for quite a few years now, because since I broke my leg, I can't tolerate close physical examination. So it is so important to get it right, you know. And I can't believe they didn't listen to you. It's just... So even sort of like when I used to have to, when I had my periods and I had tampons, that was incredibly challenging to use. And I only, in the end, managed to use tampons because I had so many smear tests. Well, they weren't smear tests, but so many examinations, because I couldn't use it. I don't know what it is. I find it interesting that Lancy says that she's got exactly the same problem. So actually, how many other autistic women have that problem? I bet no one knows.
And in my case, the whole time she was screaming at me, relax, relax. I was like, it feels like you're shoving a bowling ball up me. Can you not tell me to relax?
Yeah, that was so wrong. So wrong. So bad.
So, you know, as a couple of you said there, you know, it's very distressing to hear. And that's now the 4th time I've heard that, and get upset each time. And it's something that can easily be rectified. So, you know, we thank these people for sharing their, you know, terrible times with us. And, you know, very, very grateful. And I know that it can trigger things off with them afterwards. So, sorry to leave you on such a downer, but we are coming to the end. Please do share anything with us that we can share with other people. If anybody is willing to speak at the next time, then please do. You know, always wanting to share things around the area that we can do. The next session that we have is on the 6th of March. And we are going to try an interactive workshop, so hoping this will do. So we're going to be looking at reasonable adjustments, and we're going to have some real life examples and have you working in groups to sort of come up with ideas of what reasonable adjustments can be put into place, and see how it goes. And so, you know, used to doing it with small numbers, we're hoping it works really good with big ones. I don't know if there was any questions in there, Annette. I wasn't looking at the questions as I was going through that.
Can't see any questions, everyone.
Okay, so this will be getting uploaded onto the site to be sent out to you. Please do share with colleagues, and you know, and especially the videos that we've got. The video that we had about Nicola and her device. The reason that all that text is at the beginning is because it'll be a standalone video at some point. So we wanted that description in earlier. But if no one has any questions, then thank you so much for being with us, and we will see you at the next one. And thanks to Michelle and to Mary for being great presenters today. Thank you very much. Thanks, Michelle.